My name is Fred Schaich. I'm here at the 22nd CROI, and we're presenting a panel on women's health, women's issues, and research. We're here with Liz and Alison and Monica, and we're going to let them introduce themselves. We're going to also ask them, so we show how human these people are. We're going to ask them to tell a little bit about their history and how they got into the issues of women's issues in the field of science and health. I'll let you start, Liz.
Okay, my name is Liz Connick, and I'm a physician at the University of Colorado in Denver. And I'm an immunologist, and I actually became interested in the field of HIV in women when it became clear that women had lower viral loads than men, and nobody understood the biological basis of that. And my work since then has been involved trying to understand more about the biology of HIV infection in women and the effects of sex hormones on that biology.
Alison?
I'm Alison Drake. I'm at the University of Washington, and I'm an epidemiologist by training. I started my early career in microbiology and interested in infectious disease epidemiology, and became involved in a project early on trying to get women tested for HIV during their antenatal care programs, which was very early. It was at the beginning of a new shift of getting women tested in the state of Michigan. So I was working with the state of Michigan at the time. And then I met some new faculty members when I joined the University of Washington who were working in global health, and just got exposed to some new programs and projects that were working in Kenya. And so now my work is primarily focused on HIV prevention and treatment among pregnant and postpartum women in Kenya.
Monica?
So my name is Monica Gandhi, and I am at UCSF, and I started working in HIV infection in women some time ago in the context of the Women's Interagency HIV study, a large cohort of HIV-infected women and non-infected matched controls, and now have been focusing more of my efforts on measuring antiretroviral levels in small hair samples as a marker of exposure and adherence, and looking at differences between men and women in that.
And the conference has several ways to absorb the data or present the data. It's in oral abstracts and plenaries and also poster sessions. Y'all are lamenting the fact that there's an oral presentation right now that's being made on estrogen levels or something, I think you were saying.
Yeah.
But it's a 3-ring circus, or maybe a 10-ring circus. And so you can't be everywhere, but we really appreciate you taking the time away from something that meant something to you. But if you could kind of go over things that were relevant to women, and I think that would be of some interest, obviously, to our audience.
Okay.
I'll let you start first, Liz.
Well, near and dear to my heart, there was a poster discussion yesterday that was looking at the effects of sex hormones in women. One study suggested that hormone replacement therapy in seronegative women may actually reduce expression of one of the HIV co-receptors, CCR5, and that this might, actually protect older women from getting infected. There were 2 studies that looked at the effects of hormonal contraception also on HIV susceptibility factors, and both of these studies suggested that DMPA may increase expression of this co-receptor for HIV called CCR5. And finally, there was a study that was looking at the vaginal microbiology, looking at the bacteria that are in the vagina of women who are put on Depo-Provera, and showed that there were differences. All these studies are very preliminary, and we can't make any treatment decisions from them, but what I think is important is that they represent attempts to really try to begin to understand the biology of how sex hormones and hormonal contraception or an HRT may be affecting women's risk of getting HIV. So I really welcome seeing those presentations, even though they're very preliminary.
I think I attended a lot of the same sessions that you did, and I would just add more generally that I think a theme at CROI this year is trying to get women more involved in research And we're seeing a little bit more this year in general. Some of the sessions are more focused on women, but in general, a lot of the trials and some of the studies still don't quite have enough participation among women, and particularly young women. And from my perspective, I think a lot about pregnant women. Pregnant women are often excluded from research studies for safety concerns often, but they often can benefit a lot from a lot of the interventions that are being tested or in the early phases of rollout for other populations. So I think as a community, as a population, we should really strive to involve women more in research studies, involve pregnant women when it is safe and when they do have an opportunity to benefit. And early on, often the pregnant populations are ones that are involved early, so there's a lot of work done and they're the last group to benefit. So that's just something I would like to see more of. In addition, involvement of adolescents. They're a difficult population to work with because of, again, ethical constraints and just trying to access them in care systems. And I think we still don't know a lot about adolescents who are at different phases. Some of them are perinatally infected and now are living with HIV. Others are acquiring HIV as young women. And I think there's a lot that we can do for the adolescent population as well. So I guess I would say trying to involve more adolescents and pregnant women early in research would be a key direction.
And that's something that the pharmaceutical companies or the FDA or who is kind of being restrictive about, or is it the company who doesn't want to muddy the trial, so to speak?
Well, I think the original proof of concept trials typically exclude pregnant women because it's sort of a hot button topic, and so a lot of the drug labeling may be restrictive for some interventions, some drugs for pregnant women. But often from the investigator perspective too, it's very difficult to get with pregnant women involved in trials, and sometimes I think it's one, easier to exclude them, and two, it's instead of making it a broader population, because they have very different biology. What's happening in their body when they're pregnant is very different than a non-pregnant or even a postpartum population. And so to make it a little bit cleaner and purer, it sometimes is simpler to just make it more restricted to a smaller population rather than trying to address needs for diverse populations.
And how do you, we've kind of gone over this ad infinitum as far as what it is that are the challenges for women getting into trials. Is there any kind of a document that, like from the GRACE study, that they've created? Somebody must have created something of a guidance document for, the way in which you can either halt the inclusion of more men in the trial into more women, or are accrued. I mean, there's so much that's out there already that kind of like you already know. But companies come to us, as I was talking earlier, ATAC, to analyze how can we bring more, they're being thoughtful and asking us to be helpful in what can we do. And I'm thinking maybe there should be some sort of guidance document that would be.
I think actually in terms of that, the WISE study and the Women's Interagency HIV study is a good example of an observational cohort study where it's all women. And there have been quite good rates of retention of these women over 20 years. And so I would possibly put in a plug for pharmaceutical companies and clinical trial settings to look at observational cohort settings that are all women and techniques such that they used in the GRACE study to help bring and keep women in. It's sometimes about relationships or having it be easy for transportation for the woman to get to the site, to have childcare on site, to have, make it easier for women, given all the sort of caregiving activities that they have to perform for their families, to actually participate in research. I do think this particular CROI, a couple of very important abstracts have already been presented that I think people were waiting for that occurred yesterday, which is I think the FACTS trial, which was the look at coitally dependent 1% tenofovir gel and as a method of HIV prevention. So we had the CAPRISA 004 trial published in 2011, presented in 2010, that showed there was efficacy of coitally administered 1% tenofovir gel for HIV prevention in African women. And that was important and met with a standing ovation, and it was a big deal to have the question of a microbicide in a woman-controlled product for HIV prevention. Then we had the VOICE trial, the 1% tenofovir gel, which is the daily use of that gel. That particular arm of the trial closed down early in 2011. and the results were actually just published in the New England Journal last month. So there was this idea that daily use of 1% tenofovir gel was not effective, and all of that seemed to be about adherence with the 1% tenofovir gel. And so the FACTS trial was very much awaited, I think, to have this data presented yesterday, which was also coilly dependent administration of 1% tenofovir gel to look at HIV prevention outcomes. And again, the results were essentially null, just like the VOICE trial with daily use. So certainly they did have an adherence measure, which was tenofovir levels in cervicovaginal lavage, and it looked like, again, there was issues with adherence because it is hard for women who may not have control over her own sexual health
to deal with the
administer
potential spontaneity of a sexual event.
There's certainly that, and then there's also not having control, possibly, of your own event, or if you're at risk, the stigma of having a gel product and having a product that you have to place. And I think it just pointed to our concerns that we're not there yet in terms of a coilly administered product.
I don't know that there's any way that you can really address the issues around a woman getting more control, because it's just inherent that many women are subjugated and subservient to a man or men per se, and it's a sad fact, and that leads us to something that is going to be more permanent that a woman can take, that is not going to depend on her applying something. I mean, obviously in a rape situation there's no chance for that, but if there was even aggressive behavior on a sexual event, it's difficult for her to imagine how that would come into play. Even a ring, I guess, would be another thing.
I think rings are of great interest.
Yes.
I think
but in some cases,
of
will they be able to still offer that control in that case, do you suppose?
We're waiting for the results of the vaginal ring studies. Dapivirine is of great interest, which is a non-nucleoside reverse transcriptase inhibitor, and we haven't seen the results of that yet. We have macaque models that are very hopeful in terms of vaginal ring and gradual release of the microbicide over time. So we'll wait for that.
You suppose the best hope will be injectable, long-acting? What would be the best way?
Probably.
Yeah.
I mean, we know with birth control that that's the most effective by far.
Mm-hmm.
And I think both for treatment and prevention, probably that's the...
A lot of interest in that as well, but we don't know. Yeah, again, macaque models and early study, but we need more data.
When you look at it, it just seems to be there's so many people that are not in control of their own lives for one reason or another, and it might be just the issue around forgetfulness, or their lives are so chaotic, such as in injection drug users or alcoholics or something like that. And they are they're through this case of their own illness, whatever it might be, it makes it difficult for them to be, really in control of their what they're doing.
That's why I think the concealable methods is such a key. I mean, with the ring, it's a little bit more concealable and less likely to be detected by a partner, and if it was an injection, and that's just so different than, a microbicide gel, which is
It's
it
out
has to be
there.
stored somewhere, and it's hard for women to have control over that.
It might cause some stigmatization if when people
Definitely.
find it, and family, like they say, a lot of the women were living at home and their family would find it or whatever. I even know, I think this was one of the things that came out in Malaysia, one of the trials was mentioned, I think in the pre-conference discussion on the Grace trial. Some of the women that would come into the trial would come in and they were all excited about it. They'd take whatever it was home, and they'd find out their family was completely against them being involved in a trial. So one of the things they said was maybe it's important for them to consider bringing their family in so they can get the first hand, as they got it, rather than second hand from this person who's going to now be feeling like they've been taken advantage of, so to speak, in a trial. And I think, I don't know that is even close to the situation today. People today getting into trials yes, there's altruism, but it seems as though there's so much care put into doing the best they can for the patient with informed consents and safety monitoring boards and all those IRBs. This is all very, very strongly weighted in the defense of and the support of the patient's rights. So this is what we're dealing with here today. This is a population today that really needs to engage in the studies, women especially, because it's more difficult for women with all the baggage that comes with being a woman to get into a trial, and we have to work hard to make sure that whatever it is that trial is going to be accommodating to their needs. Do you feel maybe a support or a discussion or a focus group before the trial starts with potential women from a community? It's like nothing about us without us type of thing, before it starts, so that you can get a sense of the community that's being tested or being run through the trial, being maybe a focus group first, so they can get a sense of it.
I mean, I think that's the best practices for starting clinical trials, is to go into the community first and figure out what they want. I mean, the AIDS Clinical Trials Group has community advisory boards associated with every single site, and that's the input that they're supposed to be getting. And I know that Voice, despite all the poor adherence, had a lot of preparatory work where they went in and talked to the community. So
kind of a focus group.
It's not foolproof.
Yeah, I mean, but I think the Voice trial is important to bring up here. And then I really do want to mention the Promise trial, because I think that was so important to be presented at CROI that we should mention it for your audience. But you can have community. I mean, I think that would be much written about the Voice trial for years. But I think you could have CABs, or community advisory boards, but that may not get to the issue. And I think the ACTG, we're still. I think there's still a struggle with getting adequate numbers of women in, and so. You're right, you could have best practices, or the setup or the structure, but I think we're going to be learning from the Voice about true community buy-in versus having all the scaffolding of what it means to set up
the appearance of it,
trial.
Rather than the appearance of it has to be genuine.
Yeah,
I think
it's extremely complicated. That there's north-south issues, and there's issues of investigators coming into a cultural setting, and I think the Voice trial did do as good of a job as they could, but it ended up not
being enough or right.
Right.
I mean, the domestic. Oh, sorry.
I was just going to say, your point about partners, I think, is an important one. I don't know how much effort is really being. I mean, I think you need to have different models, so it should be mandated that every woman should involve her partner. But I think exploring that as an opportunity of, if the woman is maybe reluctant to join the trial, if she has partner concerns, to have a consultation with the partner. And we actually do that in our own projects, where we have a male staff member who talks to the other men, because they're more comfortable talking to a male member in our projects, and we have found that has been really beneficial to, one, retain them in the projects, and two, to get them. A lot of them say that they want to go home and consult their partner before they enroll in a study. And so having a mechanism to support those women who are open to that, not making it an inclusion criteria, but I think would really benefit to also sort of see what's the real world implementation of a trial with that support.
And so it might be, there are options, say, okay, we can bring both of you in together, or we can introduce him to the trial with another male individual who can kind of talk about his subjects. It depends upon what the trial is about.
Right.
And sexual protections or prevention or whatever. But I think a lot of times people say, well, that CAB doesn't represent me or my community. And so that's another issue of the challenge that you face. But you can go so far, and you can't involve everybody, but you can get a fair sampling of a genuine piece of the population.
You do bring up the Grace trial. I think that they did a good job.
Oh yeah,
it was truly from the very beginning informed by HIV-infected women, how they would want the trial conducted. It was accompanied by this formation of relationships, by provision of supplies to the women that they related to a theme, they had bags, they had things that connected them to the study and made them feel a part of the study, and so that to me was a good model of clinical trial.
Yeah, but putting this on paper and saying this, these things are important, the perspectives that were produced and the outcomes of some of the meetings. I mean, all of this would be good reference material and guidance documents for future trials, depending, of course, what the subject is, what the product is that they're evaluating.
I think that those do exist, that they are on paper, but I think it comes down to, you asked, what is the problem? Is it the drug companies or whatever? Most of the trouble in terms of recruiting women refers to the domestic clinical trials. In non-domestic trials, women are easily recruited. I mean, there may be other issues, but there are.
It's actually usually easier to get women in international trials.
It's a domestic issue, and it comes down to money, because it takes longer to recruit women into the studies. They may require more resources, and it's a lack of will. And it comes down to money. If your study has to stay open 6 months longer to recruit a sufficient number of women. But it's been shown, in the hepatitis C clinical trials, one of the drug companies, I forget which one, I mean, they were brilliant. They said, you can admit, you can recruit these many. They were trying to get African Americans into their studies because they're so, they are disproportionately infected with HCV, and they also have different treatment outcomes.
So they actually had slots, apparently.
Oh, they said that you can recruit these many, and then you can't recruit anymore unless you recruit African Americans. So they very easily.
And that's good.
Yeah, I mean, there are strategies. It's simply a lack of will and money. I mean, how important?
Or like you said, wanting to wait, because you have to perform sex stratified analysis. You need a certain number,
right?
And you have to be able to wait.
And I would argue that in international studies, it's the young women who are that group. So while women in general are being recruited, the women who are at the highest risk of infection, the youngest women are often the ones that are harder to get into projects.
And that may be the same in our country too.
Yes.
And I think it's certainly the case with males as well.
Yes.
Getting younger people, because they're the most likely to become infected. Of course, there's this natural law of diminishing returns and whatever it is, but you have men who have had the opportunity to be infected many times, and maybe Delta 32 deleted, and the kids that are coming up there are probably much more. Their hormones are raging much more and having much more sex, so their risks are infinitely increased. So we need to, and that's the population we should make sure we ensure have been entered into the trials. And again, the more you start to be specific about that, the more complicated it becomes, because you have to make sure all the ethnicities are represented and so forth. But there is specific things, as you mentioned to start out with, that there are issues that are relevant in women's issues. There are women's pathogenesis of a course of disease. Epidemiology, it's all different. So sometimes profoundly, sometimes subtly, and it needs to be defined, and it needs to be evaluated through research. So, all right, I guess we're pretty much at the end of our program. Did we cover all of what we needed to cover for you?
Tiniest plug for the PROMISE study. I mean, I think it was important, but these are HIV-infected pregnant women evaluating the best strategies for eliminating, which is the hope, perinatal transmission of HIV infection. And just very briefly, I think as probably expected, a triple antiretroviral regimen was more effective than starting ARVs late, or not giving triple with, and then just giving single dose nevirapine. So that was just important, and it confirms the WHO June 2013 guidelines for giving option B plus, essentially. So there were some issues with toxicity that need to be explored, though, in the arms of that study, and that was also important.
But they're also not the most commonly used regimens, at least in developing countries. So it could be encouraging in some ways that if short course really is inferior to triple drug therapy, that maybe a different regimen would solve some of those toxicity problems.
Well, thank you very much, Monica, Alison, and Liz. And we're wrapping up here, and I appreciate your taking the time away from the conference. As we said earlier, you're missing some good stuff, but get back at it.
Thank you.
Thanks a lot, Fred.
Thank you.